My name's Alicia Oliver, and today I'll be presenting on my project titled the Prediabetes and Type 2 Diabetes Screening Toolkit for Indigenous Communities in Saskatchewan. So I'm a dietitian and a diabetes educator who has been working on onion lake crenation in Saskatchewan for the past 15 years. As a result, I have a keen interest in diabetes as well as population health for Indigenous peoples. All right, so I would like to begin by acknowledging that I'm speaking on the traditional lands of the Treaty 6 Tory and that Lloydminster residents are beneficiaries of this peace and friendship treaty. Treaty 6 is comprised of the traditional territories of numerous First Nations, including Cree, Dene, Nakota, Saulteaux, and Ojibwe, and the homeland of the Métis Nation. I'd also like to thank Indigenous Services Canada and Nina Onaskavich, who is my practicum supervisor, as well as Betty, Nigel, Victoria, and other faculty and support staff through the entire process of this practicum. I'd also like to thank Dr. Mark Inman and all the diabetes nurses, educators, and dietitians who work in Indigenous communities throughout Saskatchewan. And finally, the amazing and resilient people of Onion Lake Cree Nation for allowing me to work with community and share pictures from one of our breastfeeding promotion projects in my presentation. So just a brief outline. So I'll be going over the purpose of my project, a bit of background and context, as well as the screening toolkit itself and what it contains, public health implications of the toolkit, and then challenges and strengths of the project and recommendations and next steps. So why a screening toolkit? So leadership from Indigenous communities across Saskatchewan began requesting screening children and youth as they deemed it a health priority. So dietitians, nurses, and other healthcare providers working in communities were asked to complete the screening. It actually was kind of difficult to know what to do, so they asked for guidance from the Aboriginal Diabetes Initiative, community dietitian working at Indigenous Services Canada, because a lot of the guidelines right now aren't feasible within communities. So I was asked to develop the safest and most reliable screening recommendations that would work in the distinct and unique Indigenous communities with the resources they had available to them. So before I start to talk about the project itself, I think it's important to provide some background and context as to why this issue was on leadership's radar in the first place. So for a bit of background and context, so type 2 diabetes is a chronic condition affecting the body's ability to produce and use insulin to control blood sugar levels. Prior to the 1940s, diabetes in Indigenous peoples was extremely rare. It could be suggested that attempts of assimilation and colonization by the Canadian government interrupted Indigenous culture, including dietary habits and active lifestyles, which led to a sharp increase in prevalence of obesity and in turn type 2 diabetes. We know that type 2 diabetes prevalence rates are higher in Indigenous populations in general at 3 to 5 times the rate of the general Canadian population. But what about the children and youth in Saskatchewan? So how are they affected by type 2 diabetes? So to try to seek an answer to this question and to determine how to set up a toolkit, I performed a brief lit review as well as a small scan. So few population-based studies exist when looking at prevalence in Indigenous children and youth in Saskatchewan. So I looked to other provincial, national, and international literature that took place over the past 20 years. Data suggests there has been a steady increase in the prevalence of obesity alongside a steady increase in type 2 diabetes prevalence across the world. These studies showed higher rates in Indigenous populations compared to that of non-Indigenous across the board. Nationally, the majority of studies involving Indigenous children and youth have taken place in Ontario, Manitoba, and Alberta. So in Manitoba and Alberta, 87% of children who have type 2 diabetes are Indigenous. And in Alberta, prevalence rates have grown twice as much in Indigenous youth compared to non-Indigenous. I also found that although prediabetes in children has not been studied a lot in Canada in the past 20 years, many international studies suggest there are higher rates of prediabetes than type 2 diabetes in children and youth. This suggests earlier screening during the asymptomatic prediabetes stage can reduce the incidence of type 2 diabetes and risk of complications related to it. So the scan I used to determine current practices taking place for screening of children in Indigenous communities. So the types of screening that most people are doing, and mainly the answers were from Saskatchewan, but the types of screening taking place are case by case if a child or teen appears high risk, as well as opportunistic screening if there's a clinical setting available, so diagnostic laboratory testing, as well as public health screenings at community events like treaty days or in schools. So the screening methods used, the age ranges that they screen are typically from 8 to 18 unless they're considered higher risk, as well as the types of screening tests being used are the point of care hemoglobin A1C, and that's a 3-month average blood sugar test, as well as random blood sugar tests, a combination of the two, or diagnostic laboratory hemoglobin A1C and fasting blood sugar tests combined. So my main takeaway from the scan was that most of the screening is inconsistent and varied, and a lot of places aren't even testing at all. So the screening toolkit itself, I included a section on cultural considerations prior to screening, and this is to ensure harms are mitigated and community involvement takes place throughout the entire screening process. As well, I included risk factors and a risk assessment tool. So Indigenous children are already considered high risk because they're a member of a high risk ethnic group. So additional risk factors, I didn't list them all here, but some are overweight and obesity, family history of type 2 diabetes in a first or second degree relative, as well as exposure to diabetes in utero. So pregnant moms who have gestational or pre-existing diabetes, it increases the risk of the child later in life. So if Indigenous children have one additional risk factor and have reached puberty, they should be screened for type 2 diabetes according to the clinical practice guidelines out by Diabetes Canada. I also included a small section on consent, as some people weren't sure what the age of consent should be for screening. As well, I included a pre-screening recommendations and checklist. So this is to ensure all steps are thought out and take place prior to a screening, and this would also mitigate harm to participants. I included a section on screening and testing options and results. It includes the best practice recommendations from Diabetes Canada, as well as 3 additional options for those communities without access to lab services that can complete blood work. I also included cutoff values for results of each test, so that participants who might require referrals, they know the test results would screen them as positive and they can be referred as needed. One of the sections that's not quite complete, it's a work in progress, is the shared and follow-up care section. We will be meeting about this to finalize it, but it will include referral trees for use in Saskatchewan. I also included a section of additional recommendations for communities, including the importance of collecting baseline data and future data within communities, monitoring infants at higher risk of developing type 2 diabetes, screening for comorbidities in children at high risk, improving communication for follow-up and shared care, continuing prevention efforts including breastfeeding promotion and addressing social determinants of health, as well as monitoring those considered high risk yearly with referrals to dietitians, working in communities for early lifestyle interventions. So some public health implications. One of them would be the economic burden of type 2 diabetes. So early screening could lead to a delay and or prevention of complications and comorbidities. Also, it could result in preconception care for the young women of childbearing age, reducing high-risk pregnancy outcomes. Additionally, data and community supports. With improved data collection within communities, this would allow them to show if there are gaps in care and support them in advocating for additional resources in their communities. Improved health with flexible screening processes led by community to ensure children are screened safely, as well as improved referral processes and shared care to support families, we would see improved health outcomes. And then I listed some potential negative consequences as well, because with an increase in screening and rates of diabetes, if there is an increase, we could see a burden on the existing healthcare system. And then communities may require additional support from social workers and or mental health if there's an increase in diagnosed cases of diabetes in children or youth. So a few challenges and strengths. So challenges to the project were limited time available for completion, especially with the pandemic hitting when it did, as well as potential for resistance of tool use by those healthcare providers less involved in the process. Limited data available for current rates in Saskatchewan. It may not be seen as priority by healthcare providers. And then strengths are communities will gain access to resources and additional supports. There'll be consistent and safe screening methods being used. And it's promising practice rather than best practices, so it ensures distinct realities within Indigenous communities is recognized. As well, it promotes community partnership. So for recommendations and next steps, the toolkit will be completed with input from healthcare providers across Saskatchewan, and this will ensure shared care and follow-up care is adequate depending on distinct community needs. And the referral trees will also be completed as a part of this collaboration. If there's an increase of screen positive cases, we will continue advocating for resources to support communities. And that's the end of my presentation. I hope you enjoyed it. And if you have any questions at this time, I welcome them now.
That is fantastic. What a great start. Thank you so much, Alicia. That's brilliant. So are there any questions? So just put your hand up. Okay. So was that a question, Anika, or was that you just were sending a chat message? Is there any, if you have a question, just put up the raise hand, tap on the raise hand icon. Okay, so no questions yet. Well, I'll ask a question. Could you sort of provide a sort of some sort of explanation as to why the prevalence rates are so much higher in Indigenous populations and youth in particular than the general population?
Well, I believe there's probably quite a few reasons, but one of them would be the cultural disruption through colonization and the inactivity and the traditional lifestyles being completely altered. As well, there's epigenetics involved. So moms who have diabetes definitely increase the risk of their children being born with diabetes as well. So that's something that we have to really watch for. And also another thing that's protective against diabetes in youth is breastfeeding. And I know just from working on reserve for 15 years, we have very low rates. Not just in our community that I work in, but also many others. So this is definitely one of the areas that we really try to promote to make sure that moms can do something to prevent it in their children and youth. There is also the thrifty gene hypothesis, and I know it's sort of controversial, but because Indigenous peoples were hunters and gatherers, and there was a feasting and famine, basically the body's, what the hypothesis is that it's more able to store energy. And so because of that and the inactivity and the higher intake of food and nutrients, it actually creates, well, the theory is that it creates this sort of perfect environment to develop type 2 diabetes because they're so good at storing energy.
It's fascinating and obviously a very important issue. And a number of people have commented on the beautiful photographs that you presented in your presentation. It's gorgeous. So thank you for that. So just the last opportunity for anyone, if they do have a quick question, just raise your hand. Oh, okay. So Andrea, you have a question. So you just turn on your microphone and video if you like, and ask away.
Okay, sorry. Hi, everyone. Amazing presentation, Alicia. That was great. I was really interested that you said increased diagnosis might mean more of a burden on the mental health system, and I'd really love to hear more about that.
Thanks, Andrea. Basically, with a diagnosis of diabetes, it can be very overwhelming for people when they're first diagnosed. We see that a lot with the adult population, but I also worry with the Indigenous children and youth. What would happen was they might feel more alone or have less supports available to them because it is it's not new, but it is in this world. So it's sort of one of those things that you just have to be prepared for. And I think if we see a lot of kids that are diagnosed, we just have to make sure we're being very cautious if we are testing, that we have all the follow-ups in place to support that. So making sure there's mental health supports, and then also social work, just for the aspects, just in personal experience, we have had some clients who are in the school system and they're in the foster care system as well. So just making sure that everyone is sort of working together as a team is really important. And so having social workers sort of involved in that is really, really important as well.